The title of this session is TGA with Aortic Arch Abnormalities. I am joined by Dr. Charles Fraser, who is known to all of you. He insisted that I only say he's from Austin, Texas, and that's it. So he's a legend in his own. He led the Texas Children for many, many years, and now he's leading Austin for a different group. Thank you so much for coming and joining us, Chuck. And Jeff Jacobs, as everybody knows. So we're going to start off the same with every session. We start off with a case presentation. The case will be presented by Emily Ribeiro.
Hello, everyone. Thank you for the introduction. My name is Emily Ribeiro, and I'm a first-year pediatric cardiology fellow at the University of Florida. And today I will be presenting a patient with transposition of the great arteries, a VSD, and coarctation of the aorta. The patient was born at 39 weeks, 1-day gestation via normal spontaneous vaginal delivery to a 33-year-old G5P4011 mother with negative serologies. Pregnancy and delivery were uncomplicated, but he developed respiratory distress requiring initiation of CPAP of 7 with 50% FiO2. His preductal saturations were 99% and postductal saturations were 91%. An echocardiogram was obtained and showed detransposition of the great arteries, a VSD, and coarctation of the aorta. PGE was then started due to his coarctation. His PFO demonstrated a restrictive flow, and so a bedside balloon septostomy was performed to provide adequate mixing. He was intubated for further respiratory support, but was able to extubate prior to surgery and was also tolerating oral feeds prior to surgery. As is routine at our center, a presurgical brain MRI was obtained, which demonstrated a small lacunar infarct and small subdural and subarachnoid hemorrhage. He was evaluated by neurology and cleared for surgery. To go over his imaging, we have a transthoracic echocardiogram. First is an apical 4-chamber view demonstrating atrioventricular concordance and normal systolic function. As you sweep more anterior still in the apical view, you can see the pulmonary artery and his VSD. When you add color, you can see a bidirectional shunt through the VSD as well as unobstructed flow out the pulmonary artery. And even more anterior is the aorta, and though not well seen here, the coronary arteries were normal. And when you add color, you can see that there was no stenosis or insufficiency, though the valve was measuring mildly hypoplastic. Next is a parasternal long axis view demonstrating that the great vessels are side by side with the aorta being more anterior, and you can also see his VSD. Transitioning to a parasternal short axis, you can see the valves here with the aorta being more anterior. And finally, we have a color compare of his aortic arch, and you can see that his arch is very hypoplastic and coarcted with a large PDA. We had also obtained a CTA, and here in the sagittal view, firstly, you can see the aorta more anterior to the pulmonary trunk, and then the large PDA and coarctation of the aorta. His transverse arch was measuring 4 millimeters, which is a z-score of -2.5, and his isthmus measured 1.2 millimeters, which is a z-score of -5.5. The infant underwent surgical procedure, which consisted of an arterial switch, VSD patch, ASD suture closure, PDA division, repair of his coarctation, and aortic arch using patch or aortoplasty. He had some junctional rhythm noted in the OR and did require some temporary pacing. His postoperative course was overall uneventful. He was able to transition to intermittent oral medications, and by discharge, he was tolerating oral feeds. Outpatient, he has been progressing very well and weaning off of his medications. Thank you for your time.
I'm going to have Diane Spicer again. Thank you so much.
Yeah, Diane, giving it multiple talks like this, I know it takes, hundreds of hours of work to put this together, and all of us are very appreciative of the amount of effort you've put into putting all these talks together. So thank you very much.
Thanks for that, Jeff. So now we're going to move on to talk about transposition with aortic arch abnormalities. And some of the things I have listed here, I'll be able to show you some nice images of and some of the anatomy. So included can be distal origin of a subclavian artery, and depending on which side the arch goes to will depend on which side the subclavian artery originates from distally. We can have a right aortic arch, which typically occurs with mirror image branching of the brachiocephalic arteries, coarctation, which can occur in multiple different forms, interrupted aortic arch, which is kind of follows on the same anatomy and takes us from the coarctation to the extreme form where we have interruption of the aortic arch, and then double aortic arch. This is an image that shows us the aorta anterior and leftward of the pulmonary trunk, and there is a right aortic arch. Here you can see the right and left pulmonary arteries coming from the very dilated pulmonary trunk, and there is our right arch and our right-sided arterial ligament. The branching pattern of the brachiocephalic arteries is mirror imaged in this case, and here you can see the brachiocephalic trunk, which was cut prior to the bifurcation, the right common carotid, and then the right subclavian artery. Coarctation is typically associated with a ventricular septal defect and anterior malalignment of the outlet septum, and it can also be associated in transposition when you have a hypoplastic right ventricle. Defects typically extend into the outlet component of the right ventricle, so we have outlet ventricular septal defects, and these can extend to become perimembranous or have a posterior inferior muscular rim. In these cases, we must describe the borders and the geography of the defect so that the surgeons know how to treat these patients, because they can have a lot of different variables. Also, we must look at these cases to assess pulmonary trunk override. So some of these cases may progress to the Taussig-Bing malformation, where you have a double outlet right ventricle. The VSDs are or can extend to become subpulmonary. Other types or other variations of the coarctation are hypoplasia of the aortic arch, or those coarctations where we have a discrete ridge, and also must be aware of the status of the arterial duct, as was presented in the clinical case by Emily. So here is a case that has anterior deviation of the outlet septum and an outlet ventricular septal defect that extends to become perimembranous. So you can see it extends between the limbs of the septomarginal trabeculation, and there is the prominent outlet septum deviated in anterior superior position, much like we see in hearts with tetralogy of Fallot with concordant ventriculo-arterial connections. And you can see what a prominent right ventricular structure this anterior deviation creates for this outlet septum. Here's the left view of that same heart, and you can see the VSD is in subpulmonary position. There is a slight bit of override of the pulmonary valve here, but not enough to call it a double outlet right ventricle. You can see some of the tricuspid valve tension apparatus hanging over the right side of the defect, and there is our tricuspid to mitral valve fibrous continuity along the posterior inferior border, which makes this a perimembranous ventricular septal defect. There you can also see the fibrous continuity between the pulmonary valve and the mitral valve. This is a very interesting case, and actually it's the case I showed you in the left ventricular outflow tract obstruction, where we had that prominent subpulmonary muscular infundibulum and the straddling and overriding of the tricuspid valve. So this case also has anterior deviation of the outlet septum with a severe subaortic stenosis. The VSD extended into the inlet component of the right ventricle, and it was actually a muscular VSD. You can notice that there are no tension apparatus attaching it to the crest of the septum, because they are straddling and overriding and attaching with a small papillary muscle in the left ventricle. This aorta was anterior and to the right of the pulmonary trunk, And you can see that there is aortic arch hypoplasia. There's a very large patent arterial duct, and there is our arch hypoplasia, very constricted at the isthmus. This is the opened pulmonary trunk and the arterial duct. Here is the expanse of the arterial duct, and you can see the wrinkling and discoloration of the intima. I'm not sure what it is about formalin fixation, but it really delineates the ductal tissue for me when I'm photographing these specimens. And you can see that the tiny aortic opening into or at the isthmus is partially encased within ductal tissue. So once this duct closed, this aortic arch may have actually become hemodynamically interrupted. So this is a very severe coarctation associated with anterior deviation of the outlet septum and a ventricular septal defect. The other important point here is that this VSD extends into the inlet component of the right ventricle, which puts our conduction axis at a more posterior inferior position where the crest of the muscular ventricular septum meets the atrial myocardium. So again, an attenuated triangle of Koch. When we move on to talk about interrupted aortic arch, this is a rare combination with transposition, and 6% of children with interrupted aortic arch have associated transposition, so quite rare. These may also be associated with right ventricular hypoplasia, so some cases where you have straddling and overriding of the tricuspid valve in a hypoplastic right ventricle also have to be assessed for their complete anatomy. The ventricular septal defects also can be associated with anterior malalignment, as we talked about with our coarctation examples. So these cases can have many surgical variables that have to be clinically assessed so that the surgeon can adequately take care of repairing all of the variables. This is a case, a plastinated case from the University of Florida, and we're looking at it from the posterior left aspect. So you can see the left appendage and the opened left atrium. There was actually an unroofing of the coronary sinus or persistent left superior cable vein. And here you can see between the aorta, which is anterior to the pulmonary trunk, there was a fibrous strand. So not a totally interrupted aortic arch physically, but hemodynamically, this arch was interrupted to flow. This is an anterior view of a heart, again, with anterior deviation of the outlet septum. The aorta is anterior and rightward of the pulmonary trunk. There's our anteriorly deviated outlet septum as a prominent right ventricular structure. And there are the posterior inferior borders of the ventricular septal defect. And this defect was quite a bit, it extended to become perimembranous, and the pulmonary trunk overrode the septum quite a bit in this specimen, but not quite to the point of having a double outlet from the right ventricle. So these features all need to be assessed prior to surgical repair. The aorta is interrupted in this case. There's a large patent arterial duct, which is joining the descending aorta. And you can see the area of interruption, which is between the left common carotid and the left subclavian arteries. And again, the entire aorta is hypoplastic. Double aortic arch is a rare combination in transposition, and many of these patients can have airway obstruction. It's typically a right arch that's dominant, and this is an important surgical consideration prior to the ligation of one of the arches during surgical repair. I'm lucky enough to have had the opportunity to photograph this specimen, and actually tomorrow I will have specimens for examination out in the exhibitor area. And I have this specimen luckily on loan from Lurie Children's Hospital in Chicago. So I do have this specimen to look at with a double aortic arch. The interesting thing about this is you can see the right arch there and the left arch here, which is the dominant arch in this particular case. The aorta is directly anterior to the pulmonary trunk, and the carotid arteries come off in a fairly symmetric fashion, as do the right and left subclavian arteries from each of the respective arches. And there is an arterial ligament in this case, which is left-sided. If we would have a right-sided ligament or duct in this case, this would look very much like the Edwards hypothetical arch description of where you can get interruptions and different anatomy with the aortic arch. So some final thoughts. Roughly about 10% of transposition cases have associated arch abnormalities. And the prognosis in these cases can be often hard to assess because there are so many other features that are dependent on how these patients will be surgically repaired. So is there anterior deviation of the outlet septum? How big is the VSD? Does the pulmonary trunk override? Is there straddling and overriding of the tricuspid valve? You can also have atrioventricular septal defects coexisting, which are rare. So there are a lot of different factors that depend on how these patients will be surgically repaired and clinically treated. And with these repairs, long-term follow-up is expected in some cases for recurrent coarctations. So thanks again for your time.
Thank you very much, Diane. I think we're really putting you to work today, and we appreciate all the efforts you've put into doing multiple talks today, which are all outstanding. Our next speaker is Kurt DeGroff. Kurt's a pediatric cardiologist on our team at University of Florida. He's an outstanding echo imager, spends a lot of time in the operating room with us, both in the daytime and even late at night. In fact, I think I saw him around midnight on Monday night in the middle of a case. And it's good to see you when it's not dark out, Kurt.
Thanks, Jeff. Good afternoon. I was asked to give an imaging talk on transposition gray arteries and aortic arch obstruction. This is going to be a little, not your typical imaging talk because there's not going to be a lot of images, but bear with me. The second thing I'd like to point out, I have a bit of a lisp. I had tongue surgery and still getting used to the new tongue. Somebody suggested that there was some talk about getting speech therapy. And somebody suggested, a colleague of mine, if I could ask to pay extra, get an English accent while I'm at it. I haven't had that yet. So the morphology has been gone over. I won't belabor this, but there's extremes of aortic arch obstruction from a simple coarctation to a tubular hypoplasia to interruption, and this has been discussed. Here's a CAT scan, a 3D example of interrupted arch. You see the left subclavian coming off here, the duct feeding descending aorta to type B interruption, and anterior aorta coming up with the transposition. What I did want to talk about is something that sometimes unnerves me is you have a transposition and the arch is a little bit small, and you're asking yourself, is it good enough? And is this going to be a coarctation or is this just a little indentation? And putting transposition aside for a second, we often report the inability to rule in or rule out coarctation in the setting of a duct. We often recommend serial echocardiograms, wean the prostaglandins, see what happens when the duct closes. But with transpositions, you may not have that luxury. There may be some dependencies. A lot of hearts just do well with the atrial septostomy, but some require that duct to be open. And one of the reasons to talk about this is this STS data. I understand this is going to be gone over in detail later. But you look at mortality for arterial switch operations, 2%, and mortality for arterial switch procedure plus arch repair is more than double. So you don't necessarily, what this tells me, you don't necessarily want to go in there and fix the arch when it may not need fixing. And is this due to surgical techniques or is it due to the milieu, what's going on with the heart in its entirety? I don't know. But it's probably some combination of that. And we maybe don't want to be that cavalier about just say, oh, go ahead and repair the arch when it doesn't need to be repaired. And all of us, most of us are familiar with why, several reasons, but one of the reasons why it's hard to call a coarctation sometimes is theoretically ducts in that area and flow can go around the obstruction with the duct. And then, but when that duct closes, the orifice gets more restrictive. And this is what you don't want to happen. This was a case of transposition. And here's the pre-op angiogram, looks pretty good. And then 6 weeks after the surgery, this patient showed up with severe coarctation. So you don't want that to happen. So can we reliably predict coarctation when there's a TGA? So to answer that question, investigators have broken up the aortic arch as a normal aortic arch, as aortic arch with coarctation, and all these various measurements, and then taking all sorts of ratios of these measurements to see if there's one that predicts coarctation or not. This group early on looked at echocardiograms of normal control subjects, aortic arch, and patients with coarctation. And the numbers in the parentheses are the diameters of the controlled normal arches. And then outside the parentheses is a mean of patients with a coarctation. And you see there are differences. They could have come up with a potentially equation here with this data, but it was just pointed out like this, and there was no equation or anything derived. So there have been investigators trying to come up with a ratio to predict coarctation, and they're trying to find an indicator that separates out patients who had cardiac surgery or coarctation versus normal controls. Now, this is retrospective studies, most of them. So these patients were already selected by some means by clinicians and surgeons, and they were just trying to look at those versus normal controls, see if they can come up with a ratio that was different for those two groups and maybe can separate out those groups. Also comparing those who went for coarc surgery versus control patients with only a PDA, not just an arch without a PDA. Also, others have done study groups and control groups that include or don't include a PDA and other congenital heart defects. And then even more so that another group suggested adding to that those findings with indicators of bicuspid aortic valve, posterior aortic shelf, continuous left to right PDA shunt, etc. I mean, this screams to me that we need development of a scoring system for this kind of thing, and even including transposition. Some of these studies include parts with transposition. And obviously it calls out for a large prospective study involving infants with and without coarctation, with and without ductus, and with and without other congenital heart disease. So here's kind of a summary of over the years, people trying to develop this ratio. This initial group looked at pathology specimens of normal versus coarctations, and they tried to normalize the measurements of the arch with comparing it to the size of the ascending aorta, descending aorta. They talk about the pluses and minuses of doing that. The next group was what I presented already, the echo measurements and the averages. The next group developed a diagnostic flow chart involving isthmus size, phasic versus continuous flow. But it worked, but it doesn't account for various patient sizes. The next group, I think there are a number of labs that use this. They introduced a carotid subclavian artery index. So that's where the ratio is on the numerator, diameter of distal transverse arch divided by the distance between the left common carotid and left subclavian. And if that ratio was less than 1.5, it suggested coarctation. Another group focused on ID ratio, which was the isthmus diameter divided by descending aorta diameter. And if the ratio was less than 0.64, that was suggestive of coarctation. They did a little small prospective study of their own after the retrospective study that developed this ratio. And they had to use, in addition to the ID ratio, the presence of a posterior aortic shelf in that scoring system, and it was successful. Another group we're getting later on in the years, 2008, verified these ratios, the CSI ratio and ID ratio. Again, a retrospective study like most of these are. Next group came up with a different CSAI of 1.1 that worked better for them. ID ratio didn't work well for them. Next group, similar, different CSI, and again, ID ratio did not work well, and so forth. This group, a little bit different. They say look at a 4-chamber view, get the area of the RV compared to the area of the LV, and you get a ratio, if it's greater than 1.3, it's suggestive of coarctation. Obviously, in transposition, that's going to be a little different. I don't think you could just flip these ventricles because I think they're going to behave differently with different hemodynamic states. They also found low RV systolic strain rate suggests coarctation. So there's coarctation, and then there's aortic arch hypoplasia. If you're going to go fix the coarct, you need to fix the arch as well. With coarctation alone, not transposition, assessing the ascending aortic arch hypoplasia via imaging typically determines the optimal surgical approach. And so the surgeon can decide if they're going to do a thoracotomy or sternotomy, the sternotomy fixing the arch and the coarct. But with transposition, with the one-stage repairs and coarctation, if you look in sternotomy, one can make a decision about, obviously, about the aortic arch hypoplasia based on imaging as well as the surgeon's visual inspection. And here, in one sense, one can be fairly liberal about performing aortic arch reconstruction, even on borderline cases. But we've got the caveat that I mentioned before that the mortality rates are over doubled for aortic arch and arterial switch. And then another caveat is there's evidence that certain aortic arch reconstruction techniques lead to inefficient flows from dilation, decreased distensibility, graft mismatch with surrounding tissue, and all that leading to unfavorable aeroventricular coupling. And I'd be remiss if I didn't give a talk of some simulation work, because that was the start of my career doing some of this stuff. But this is not my group. This is a different group. Looked at numerical models using fluid structure interaction analysis. So that's computational fluid dynamics and computational mechanics models, which are very sophisticated compared to what we were doing just 5 or 6 years ago. But still, it's a work in progress. This group studied optimal surgical repair shapes and optimal surgical materials used to optimize the repair. And in order to optimize it, they looked at various fluid mechanical issues, including wall stress, and they tried to optimize those. And again, this is a proof of concept thing. This is early on in development, but you can see, like, people have been talking about developing surgeries for Fontans, here surgeries for the arch ahead of time, numerically, to try to optimize that. That's in our future. And then taking that to the extreme, not talking about transposition for a second, these aortic arch reconstructions for Norwoods, there's several groups looking at these numerical models, trying to optimize those, which is kind of the extreme of this. So back to the ratios. Should we use these ratios at all to predict coarctation? And if you're asking that, you want to ask yourself, are echo measurements reliable enough? And then question that. So here's a simple aortic arch image, and I got the same exact aortic image next as well. And say you want to measure the narrowest point, for the sake of argument, call it isthmus. When we're in our cardiology conferences and people state these measurements as if they're gold standard and accurate to the 100th degree, they're not. There's problems with issues with probe resolution for the echo machine, and as well as human error. And here's an example of human error. You got that measurement, and then somebody comes in, maybe the same person or a different person. Ignore that measurement there for a second, but you get the second measurement here. And, those measurements come to 2.4 and 4.7, and at 2.9 kilo neonate, the z-scores vary from -4.7 to -1.6. So if you had a scoring system and you had z-scores in that scoring system, you could be way off just by this human error that's there. I think that's recognized, but sometimes we forget about it. And then in addition to that, there's resolution of the echo machines we use. So the definition of image resolution is minimum distance between two objects where one can discern by imaging that there are two separate objects. So here's a cone of imaging, and you have along the scan line, you have 2 points, and your axial resolution with a 10 megahertz probe is 0.3 millimeters. And then you look at lateral resolution. I won't go into why this is, but that's the resolution across the screen. And ignore this for now, that would be 3D issues. But this is a resolution across the screen, and lateral resolution is typically always less than axial resolution. And here are with a 10 megahertz probe, our lateral resolution, where we cannot distinguish when it's two objects are close together, less than 1 millimeter apart. It just looks like a blur, and I'll show you an example of that. So there's problems, there's issues with resolution, the machine we use. And here's maybe help understand what we're talking about with this. And this actually applies to the ultrasound machine. This applies to light microscopes. This applies to electron microscopy as well. If you have two structures, these two dots here, that are greater than 1 wavelength apart, and they will be displayed as two distinct structures. So here we have high frequency probe, small wavelength, and we're getting two structures that are greater than 1 wavelength apart. And when it's displayed, you see two structures. If you have a large wavelength probe, a low frequency probe, adult probe, whatever, then that's less than 1 wavelength apart, and the 2 points merge together, and you can't tell, whether it's two or one structure that you're looking at. Back to human error for a second, intra-observer variability. This came from a paper, I think there's some authors maybe in the room here, recommendations for quantification methods of the PGECO. And just focus on this for a second. Look at these dimensions. And if I gave this arch to everyone here and said, just measure the aortic isthmus for me, you can see I might stretch this out a little bit. Same thing on the other side. There is human differences in here, either intra or inter-observer variability. So to get a little better handle on this, I went down the rabbit hole of measurement error. So measurement error is, you can put it in an equation to help understand this. So M is the measurement of an object, the length of an object or the width of a vessel. So that's equal to the true dimension of that vessel or object, plus the deviation from true dimension. So the deviation from true dimension can be broken up into two items. And this gets, if you read the literature, this gets a little confusing. B is a systematic error. That's also called a bias component, and also refers to accuracy of your measuring device. And this is similar. An example of this is miscalibrating a weight scale. You didn't zero it out before you put that thing you're trying to measure weight on. And also probe resolution, which I just talked about. And then the other factor is random error. It's a random component of error. It's also referred to by precision and agreement. And an example of this is intra-observer variability. And then something like, if you were, maybe not the arch, but maybe some other structure, if it changed dimensions depending on respiration, and you're just taking into account the cardiac cycle, you'll develop a random error there. And even if you compensated for respirations, but you didn't compensate for some respirations being deeper than others, and that vessel changing, again, that's random error. So the reliability of a measuring device, in this case an ultrasound machine, is reflected both in a systematic error B and the variance of the random error. The average of the random error typically will be 0, but the variance is just a kind of scatter plot of the different measurements, how varied those are. So with that, it's difficult to find a study that assesses reliability of the aortic arch dimension measurements by echo in neonates. And from a non-statistician's point of view, to me, things start piling up and I get suspicious. You'll hear me in a cardiology conference that's always saying that's within measurement error. So, there's things I've talked about, systematic error with resolution using a 10 megahertz probe. It's 1 millimeter apart that you can't distinguish if it's less than that. And random error, one way to quantitate that, as the one paper did, is took the standard deviation of the intra and intra-observer variability, and something similar to an arch, they get a random error of standard deviation of 0.5. So add that up, 1 and 1.5, and you're trying to measure a 2 millimeter vessel. we have to be real cautious. And then on top of that, Lopez points out when you're taking two of these measurements and dividing by them, there's a calculated parameters both in the numerator and denominator that have their errors, like systematic error and random errors. You may be, enhancing your error quite significantly. So my purpose here today was to try to get through this without my tongue getting tired. Is introduce and review various 2D echo ratios that have been developed over the years to try to predict coarctation in the aorta in neonate, and discuss. I wanted to discuss reasons why we may not be so cavalier about the decision of whether or not to repair a borderline coarctation arch in transposition, and then suggest the collective. Let's take our heads out of the sand moment. Echo is a good measurement device, but it's not perfect, especially when dealing with such small structures. And thank you for your time.
Well, thank you, Kurt. That was it's actually fascinating talk. Very well done. Chuck Fraser was sitting next to me and he whispered in my ear, he agrees with everything that you're saying and you're his soul brother. So that's that was a very, very impressive talk. Our next speaker really needs no introduction. Chuck Fraser was the chief of cardiac surgery at Texas Children's and now is the chief of cardiac surgery at the University of Texas in Austin. One of the highlights of my life has been being a friend with Chuck since the 1990s. He's always somebody I looked up to as one of the true leaders in our field on multiple levels and in multiple domains. And Hani and I were very excited when Chuck agreed to come and speak at our meeting. And today he's going to talk about surgical approaches to detransposition or Taustig Bing with aortic arch hypoplasia. Chuck, you have the floor.
Thank you, Jeff. Thank you all. It's great to be with you this afternoon in Florida. I woke up in Austin this morning a little early, and this has been really fun so far. All these presentations have been fantastic. And I'm betting we're going to have a little bit of a lively discussion during the Q&A, hopefully. That last presentation just hit it home for me and really resonates with a lot of my opinions. So interestingly, Diane, our experience, and now just over 500 arterial switches is about 10% of the patients have an arch problem, just as you suggested, and we've seen them all. We've seen double arch, we've seen arch interruptions. That decision of intervening on the arch and the tweener arch is the hardest one. I would take a little bit of disagreement with Dr. DeGroff. If the surgeon leaves the operating room with a significant residual hemodynamic arch problem, it's the surgeon's fault. And we should not do that. That can be the difference between a marginal switch getting through and not. So that sounds maybe a little tough, but that's what I believe. So this is where we are. We're at a new medical school, University of Texas Dell Medical School. It's been a great run so far. I don't have any disclosures. We'll talk a little bit about some unpublished data. And this is our collective Texas Children's and Dell Children's Hospital experience. For sure, the arterial switch is my favorite operation. I think most pediatric cardiac surgeons would agree. It's the most gratifying operation. I want to review some of our integrated treatment strategies, consider some surgeons' perspectives on outcomes variability, and then review with you my own practical experience. Just as Dr. DeGraw said, it's a head scratcher, isn't it? Why can we do so well with simple transposition and not so well when we throw in other problems? And I think it's not the arch reconstruction. A pediatric cardiac surgeon should know how to do a safe, reliable arch reconstruction. So it's the other issues that I think are at hand. And again, historical literature, great outcomes variability, and we're just looking at 30-day mortality there. More recently, a little bit better. Our collective experience from Texas Children's and Dell Children's, as I said, is just short of 500 arterial switches. We had 2 deaths in the previous millennium. So I had a Taustig Bing patient with a near interruption who we had trouble with the PA reconstruction. I'll focus on that a little bit later, why that was a problem. And so that was about 97. My new colleague, Dr. McKenzie, had a death in about 98. We went the entire millennium until about 3 weeks ago. And unfortunately, Dr. Mary had a transposition VSD death. So it's a serious matter when we have an arch problem in association with transposition. And then, as also was alluded to by some of the previous speakers, then we face the reality of reintervention. And this is where I do have strong opinions about how we reconstruct the arch, because the incidence of arch reintervention in this era should be extremely low. Now, we have other reasons to have interventions in these patients. So these are my opinions. Transposition or Taussig being anomaly with arch hypoplasia. I believe most of the time you can get the answer with echo. Now, I was trained, and I'm not sure there's anyone here who's worked with Wes Vick at Texas Children's, but I can remember sitting at the bedside as a young cardiac surgeon with Wes and the sonographer and the echo probe, 30 minutes, an hour, looking. And he was persistent enough and gracious enough to stand at the bedside with me, and we'd sort it out. Now, these days, it's easy just to get a CT scan. We can just send the patient to the CT scanner. But that's not an innocuous decision, in my opinion, and we could talk more about that. But I think the surgeon has to sit with the sonographer, the ultrasonographer, the cardiologist, and look at the images. And most of us don't think in Z-scores. So when I get a report in Z-scores and someone says, -2 Z-scores, -2.5 Z-scores, I'm having a hard time knowing what to do with it. I do like the old weight in kilograms +1 rule as a minimum starting point, but the surgeon has to look at this. And then it has relevance in our operative planning. What are the brachiocephalic origins? And I'll expand on that in a second, but the unknown aberrant right subclavian artery can be a problem. So how do we plan these operations? This is paramount in my opinion. We start out with a really liberal and deliberate discussion with our anesthesiology colleagues. I prefer 2 arterial lines, usually a right radial, except in the setting of an aberrant right subclavian, and either an umbilical or femoral arterial line. I'm okay with the femoral CVL if the umbilical venous catheter maybe is malpositioned or it's too old. We're liberal with transesophageal echocardiography, and the probes have gotten better and better. Talk a little bit about NIRS and bitemporal transcranial Doppler in a second. Our perfusion strategy really has evolved from the original sort of Melbourne group approach, high flow, low pressure, pH stat, adjudicated cerebral flow with bicortical NIRS, bitemporal transcranial Doppler, almost never use circ arrest for these patients. And we've become a little bit more circumspect about profound hypothermia, usually 22 degrees, just to give us a little bit of margin in terms of flow. Separate cable cannulation in all but the very smallest children, left atrial line, peritoneal dialysis catheter. We haven't changed our cardioplegia in many decades, and then our flavor is milrinone, calcium, and epinephrine to come off. The choreography in the operating room, we call it the triangle of trust. I'm sure this is very familiar environment to everyone, where the anesthesiologist, the perfusion, and surgeon can see each other, and we favor a lot of liberal, very direct communication. The whole idea of how to cannulate these patients and the adjunct cardiopulmonary bypass techniques is fascinating to me. When Frank Pagula first presented his paper on what was then regional cerebral perfusion, we now call antegrade cerebral perfusion, it was like an epiphany for me. Sure, why not? Sew a graft on the innominate artery or subclavian artery. Don't fool around with cannulating the small ascending aorta. So we're going to put a 10 French arterial cannula in. We'll sew a 3.5 graft. We're going to put an 8 French. We'll sew a 3 millimeter graft. It gets everything out of the way. It's extremely helpful. And then in those cases where we believe there's going to be an inadequate arch, we'll cannulate the duct as well and proceed with the operation. This is an old slide when we were using the Somanetics device. We're now using the Edwards device, which is very nice readouts. And again, we're in constant dialogue with our perfusionists and our anesthesiologists about the adequacy of perfusion. So this is a perfect example of what Dr. DeGroff just looked at. And this is the one we'd see at conference about once a month. And again, what's the surgeon to do in this situation? Well, first step is to go back and review it again with the echocardiographer and ask to have another view, another look at the echo, or go back to the bedside and do another echo. And if my arm is twisted, then sure, we'll go for a CT scan. I do want to come back to that point, hopefully when we have some talk, because anesthetic for an MRI, anesthetic for a CT scan, anesthetic for a balloon atrial septostomy, travel to the cath lab, travel to the CT scanner, travel to the MRI scanner. There's a cost paid there, and it's more than just a financial cost. Then the perioperative management, this is an interesting one that's occurred to me of late. So we have some new intensivists in Austin trained in storied centers, and the dialogue is, well, we're ready for that slump that's going to come at 2 o'clock in the morning. And we all, of course, have lived that at various times in our careers. And the question is, can we anticipate it? And I think we can. And hopefully we've gotten better and better in that. And then the rest is sort of garden variety for you all. Peritoneal dialysis is something we use liberally. Mild hyperventilation, we do think the LA saves lives. And that's because the EKG can be very misleading. And in those marginal situations, we'll accept lower blood pressures early on. Let me just reemphasize communication. And for those of you all who are young and getting started, a text message to an attending surgeon in the middle of the night is not a form of communication. It is a dangerous way to communicate. It is a phone call. So let me go back. So the way I think about these is, number one, we're going to plan for a longer operation. And what I've done is, if you're going to swim across the lake, you can try to hold your breath all the way, or you can break it up every 100 yards. So I'm going to go and I'm going to fix the arch, and I'm going to take the clamp off and reperfuse the heart. Then I'm going to look inside the heart and close the VSD. And if I'm sure that I can proceed with the switch, I'll take the clamp off again. And then I'll proceed with the arterial switch. So 3 cross clamps rather than a long continuous cross clamp has served us well. And then what is the decision tree if I can't proceed with the switch? What's my bailout strategy? We need to get the arch completely repaired, no residual obstruction. And the choreography is a very detailed timeout and planning with the team. And expect that the patients are going to be delicate in the postoperative course. Now, I'll briefly go through our approach to arch advancement. We've talked about this lengthily and broadly. It perplexes me still why more people haven't adopted this technique. It is a very easy operation. And we take advantage of the fact that children's blood vessels are so elastic. We don't need to put patch material in most children. So widely mobilize the brachiocephalic vessels. This is a normally related great vessel situation, but it's the same operation we would do for almost all patients, including those with the right aortic arch. Ligate the ductus, tourniquets on the brachiocephalic vessels, care with the recurrent laryngeal nerves, mobilize the descending aorta down to about the second intercostal, distal clamp, proximal clamp, excise the ductal tissue, spatulate the cut ends, advance it up underneath the aortic arch. It will always reach. It will always reach in a newborn, almost always reach in a small child. As patients get into their nearing adolescence, a little different matter. And this is what we think it should look like. This is the sort of arch. There is no patch material in this arch. You can see the rudimentary distal aortic arch there. So it's a little pocket. And the incidence of recurrent obstruction or need for intervention has been extremely small. Dr. Mary published our series almost a decade ago, and some of these patients were arterial switch operations. And then there's some strange ones, and we see this a lot in patients with a Taussig-Bing anomaly, where you have this giant pulmonary artery and a minuscule ascending aorta. And of course, these patients are almost all going to have an arch problem. And so getting that to sit right can be very challenging for the surgeon. And so we've done some things that are a little bit creative in terms of the way we reconstruct the arch and bring the neo-aortic root up underneath the arch. Now, these days, I might do that a little bit differently. That would be a setting where I might augment the ascending aorta with a little autologous pericardium or something. But getting this reconstructed primarily and then proceeding with a coronary translocation would be our approach in these big great vessel discrepancies. So this is where I think the problem is. This is why I think that the outcomes aren't as good. It's not the arch reconstruction. It's all the other stuff. So we're going to expect coronary artery challenges. We're going to look for juxtacommissural origins, intramural coronaries, long looping, so-called type E coronaries, single coronaries. We expect an outlet problem. We're going to look for side-by-side great vessel relationships, and that's particularly challenging for the neo-pulmonary reconstruction, meaning we have to be willing to bring the neo-pulmonary anastomosis out on the right pulmonary artery, and then there can be some really challenging ventricular septal defects. I believe in other talks, there's going to be a lot of conversation about the coronary branching variability. We have to be able to handle them all. The key is minimizing axial torsion. We do favor trapdoor flaps. It's more forgiving in my hands, but the surgeon has to be capable of performing an effective coronary anastomosis, irrespective of the branching pattern and origin. And then, again, my experience is we have to be creative about the neopulmonary reconstruction sometimes so that we keep the anastomosis off of the coronary arteries and off the branches. This is, of course, is the one that we worry the most about. A long intramural coronary coming behind a pillar makes for a challenging translocation, particularly if that's a side-by-side great vessel arrangement. And, of course, a lot of times we have to unroof the ostium to make that work. Now, in the Taussig-Bing anomaly, these are really magnified to an extreme. And, you know, I was curious about some of the cases that were presenting this morning. I know for sure at least two of the cases that I saw presented, I would have done a switch on and not a Nikaido, for sure. And maybe I'm wrong, but I will tell you that I think sometimes we get down a rabbit trail with our preoperative imaging. So when we see a side-by-side great vessel relationship, you know, the cardiologist will often say, oh, we need to identify the coronaries. I know that there's going to be a worry about the coronaries. So I don't really need to have a bad night the night before knowing that it's intramural. We need to look at the outlet. So this is one such case. So I'd be curious to what people would do with this. And this is not a misleading echo. So I'll bet you in some centers, this patient would have a Nikaido. We spent a lot. Nancy Ayers was the echocardiographer. She's very skilled echocardiography. This patient cannot have an arterial switch. Pulmonary subneo-aortic area, very small. But just as Merrill alluded to earlier, the sinuses of the pulmonary valve were essentially normal. And this is how we approach that patient. We look down through the aortic valve, and sure enough, that could all be resected. And so we have to be prepared for that when we have these unusual arch presentations, because I think many of these patients can proceed with an arterial switch. And this patient I've gotten follow-up on. So this pulmonary valve, which is now the aortic valve, is normal. It's completely normal. Then finally, some will sneak in on us. And these are the ones that the surgeon hates to see. Arch obstruction, we had a big membranous VSD, and then coming off postoperatively, multiple anterior muscular VSDs. And very hard for the echocardiographer to discern. Certainly I missed it. And we had to go back and get after these. So hello from Austin. This is our new leadership team there. We've got a We got a great group going there. This is all the people we've hired in the last 5 years. It's been really busy, but I couldn't miss this chance, Jeff. So George Arnatakis just took over as the chief of adult cardiac surgery at the University of Texas Dell Medical School. George did his first case on Tuesday, and George just came from University of Florida. So finally, plan carefully, communicate thoroughly, get the arch durably repaired, expect the unexpected, have a plan B, think about alternative perfusion strategies, but have high expectations. Thank you very much.
Chuck, this is an incredible talk, amazing experience. Thanks for all the wisdom, little tricks that you shared with us. I'm sure there will be a lot of discussion about this. So thank you so much. The next talk is by Dr. Karablou, data from CHSS, the database about the transposition of great arteries. Tara, sorry we are missing you here. We wish that you're with us. I know that somebody has to do some other work, so thank you so much for doing that and appreciate your talk.
Great, thank you, Hanny, and thanks to the moderators and the program committee. So I will be speaking about the Congenital Heart Surgeon Society data vis-a-vis detransposition. And hopefully I can advance my slides. There we go. I do have a consulting relationship with Edwards Life Sciences, but nothing that will be discussed or biased be in this presentation. So before we begin, a brief digression and a question from an earlier era. What is better, an arterial or an atrial switch? Well, if you're this guy, you see a boat coming to rescue you. And if you're this guy on the boat, you think that the land is going to rescue you. So in some ways, it's about perspective. So the story of DTGA, both from the patient and the provider perspective, is a journey through time. And when we first start, let's get the baby cleaned up and fed first, and we'll see how many new followers it has. Later, I child-proof my house, but they still get in. And finally, urology department, can you hold? What do you think? So much of the discussion and knowledge regarding the management of DTGA comes from the courage and the prescience of a surgical giant, Dr. Mark Delaval. In 1994, Dr. Delaval published a paper detailing his journey with the arterial switch operation from 1987 to 1993. The title of this landmark paper was A Cluster of Surgical Failures, Application to a Series of Neonatal Arterial Switch Operations. And it was transformative and still is to surgeons. At the beginning of this journey, Dr. Delaval had 52 arterial switches with 0% mortality. However, following this, 6 patients numbered 53, 55, 59, 63, 64, and 68 all died. He reports in his paper that his initial euphoria at having 0 mortality in his early experience gave way to increasing concern with these patients' series of deaths. So what to do in this difficult situation? How do we make sense of this? 4 main reasons in the paper were postulated for the series of deaths. Could it be chance alone? Could it be changes in the procedural or patient risk factors over time, such that higher complexity patients were coming to surgery? Was it human factors and suboptimal performance? And Dr. Delaval focused on the surgeon's potential role in this. And finally, was it variation in surveillance or measurement? Dr. DeLaval commissioned the help of Dr. Jean Blackstone and Dr. Kirkland to help the GOS unit understand the results and the relationships to the largest prospective contemporaneous cohort, the CHSS TGA cohort. Shown here is the GOS series and the mortality in relation to the estimated mortality risk based on the larger CHSS cohort. Note that in the initial experience, the mortality at GOS was well below the estimated nearly 3% risk of death from the CHSS cohort. However, somewhere around patient 59, this relationship changed and an inflection point was noted such that the GOS mortality rate exceeded the estimated or expected risk based on a benchmark, which was the CHSS cohort. In a courageous and transformative step, Dr. DeLaval elected to visit 2 centers, which were low-risk centers based on the CHSS experience, to learn from the surgeons and care team. He then began a period of retraining. Note at the bottom of the horizontal how these particular initiatives impacted the mortality rate, such that after this voluntary retraining and visits, there was 1 death in the subsequent series of patients. With this, let's return to the journey through time as seen within the lens of the CHSS transposition data in the past, in the present, and a vision for the future. The CHSS transposition cohort enrolled newborns less than 15 days of age who had a diagnosis of detransposition of the great arteries and were admitted to a CHSS institution. They enrolled patients over a 4-year period from 24 centers. They did include patients with VSD and pulmonary stenosis, but not with other major cardiac lesions. Note the changing enrollment characteristics over the study period such that in 1985, only 40% of the patients had arterial switches, which is shown in red, as opposed to the end year of the study in 1989, where more than 80% of the patients underwent the arterial switch operation. There were 891 patients enrolled and 830 who initially had repair. Early survival was examined in this 210 publication of mine during my tenure as the CHSS Kirkland Ashford Fellow. This risk-adjusted nomogram demonstrates the 1-year estimated mortality following the repair of transposition of the great arteries over time. Note that, or at 1 year, as a function of increasing case volume. Note that there is a relationship whereupon at 20 cases per year, mortality decreased. So why was this? Because the transposition cohort, as you've seen, circumscribed a change and encompassed a shift in repair type from the atrial switch to the arterial switch, we created an interaction term to further investigate what was at play here with this volume outcomes relationship. And what we found was that the CHSS cohort declining mortality as a function of case volume was because it captured the learning curve of the arterial switch operation. The outcomes of the atrial switch operation are static over time, but we got better with the arterial switch. But we know that survival is not the sole metric on which we should evaluate our outcomes. Erin Colbert and her colleagues studied health-related quality of life outcomes for 306 of the 708 survivors at 11 to 15 years post-repair. Noted here are the mean scores within the Child Health Questionnaire for the transposition group as opposed to published norms. Note that patients post-repair, whether atrial, arterial, or Rastelli, did better than published age and gender matched norms in nearly all domains, in fact, 8 of 9 health-related quality of life domains. Importantly, the repair type was very important in determining health-related quality of life outcomes, such that the arterial switch operations patients did better in 5 concepts as compared to the atrial and the Rastelli patients. Moreover, on multiple regression analysis, the arterial switch operation was one of the most dominant factors leading to better concept scores in the Child Health Questionnaire. So we have learned that early survival improved over time with the arterial switch operation, and that health-related quality of life in the midterm were better among patients having the arterial switch operation. What about later outcomes? Paul Devlin addressed these questions in his study, which was the Maxwell-Chamberlain paper at the 2019 STS. The same cohort, but now we're following these patients up at a maximum of 32 years and a median of 20 years post-repair. 100 patients responded to the PEDS quality of life instrument, and the morphology of the respondents demonstrate, as you see here, a preponderance of patients with simple TGA. Survival here is shown on the left, and the corresponding hazard functions are shown on the right. Note, interestingly, that survival is better for the mustard patients, appropriately in goldenrod or mustard colored, and lowest for the senning patients shown in blue. The hazard functions give us the answer. Survival for the mustard patients is represented here by a 3-phase early hazard, a constant hazard, and a steeply rising late hazard function that is not present in the senning and arterial switch operation patients. Note that the survival is lower in the arterial switch patients because of the prominent early hazard phase due to the era and the learning curve that we talked about before. This has now been abrogated, and the hazard is constant and not rising in the late phase. Generic scores for the PEDS quality of life tended to be higher in all of the domains for the arterial switch shown in red as compared to the atrial switch patients shown in blue, but these differences were not statistically significant. The same results are seen within the cardiac module of the PEDS QL. Arterial switch patients did better in all domains, but not statistically significant. However, the mean or the minimum important differences for this questionnaire is 4 percentage points. And as you can see, the minimum important difference was reached. And moreover, univariable analysis did show a benefit to the arterial switch patients. I highlight in green here the multivariable factors associated with improved functioning. The reason for this is note the poor R-squared value for all factors, which were found to be importantly associated with the endpoint. The R-squared is the amount of variation explained by all factors in the model, and note that the total score only explains 17% of differences in health-related quality of life scores across the spectrum of anatomic repair types. Similarly, in the cardiac module, only 35% of the expected variation was explained by risk factors. So clearly, we're missing a lot here. Anusha Jaga expanded on the late functional health status in this 2020 paper, where longitudinal health-related quality of life was examined in this cohort. The study chronicled the serial examinations among respondents at 3 time points. We saw the CHQ at the year 2000. In 2010, an SF-36 was administered, and you saw Paul Devlin's PEDS-QL, in which 100 patients responded in 2017. These histograms demonstrate the results of the short form 36, which showed in the physical component summary scores and mental component summary scores that the DTGA patients did better in all domains corresponding to the healthy reference group. Why is this? Why do people with complex CHD fare better than norms? A theme we have seen several times in this journey. One is response shift, whereby people change their context and may have lower expectations. 2, the disability paradox, where different perception between observers and patients may be at play. And finally, a sense of coherence. I need to feel okay to be okay. So, armed with our knowledge of the past and understanding of the present, what does the future hold? What is next in the horizon for DTGA? It is ironic indeed when discussing the future, we must return to the past and to the courage once more. In the last page of his paper, he discussed 6 inferences and conclusions that are ideally suited for this vision of the future. And these are highlighted here. Number 1, a system of continuous monitoring of surgical performance based on an external standard. 2, outcome measures other than death can be used for refinement and quality control. 3, analysis of risk factors. 4, should this be inconclusive, a change in protocol. And 5, present experience demonstrates that retraining can reset the failure rate, something that the Northern New England Quality Collaborative established unequivocally. And Mike Gay's work with the PC4 PHN Collaborative demonstrated the same thing. These elements have been cornerstones of the CHSS since its inception as a mechanism for surgeons to discuss challenging cases and solutions in a transparent forum. Going forward with the newly imagined CHSS CRQ, these types of activities will be further actualized in the hub and spoke model. This model features mechanisms for institutional and surgeon level feedback reports, the ability to visit and observe colleagues in round robin activities, and constant disciplined introspection about one's results and one's alignment with established benchmarks. In a most fortuitous reprise, T.S. Eliot reflected on this notion of rediscovery in a person's journey through time. T.S. Eliot said, "We shall not cease from exploration, and at the end of all of our exploring will be to arrive where we started and know that place for the first time." Thank you.
Thank you so much, Tara. Tara is a great partner, great surgeon, and you could see she's a surgeon scientist. She has a repository of data that very few surgeons have, I admit, at least for myself. So thank you so much for a great talk. Next speaker, Dr. Brad Marino. He is my partner, the co-executive director of the Heart Center, Congenital Heart Center at the Cleveland Clinic, chairman of pediatric cardiology. Maybe talking about transposition of great arteries with aortic arch abnormalities, late outcome.
Thanks, Hani. Thanks, Hani. Thanks, Jeff. Thanks, Chuck. I want to put us back now towards our TGA aortic arch abnormality patients and what these late outcomes look like. Dr. Frazier gave you a little bit of taste of it, but I'm going to take you into a deep dive. So my outline, first we'll talk about what actually is a late or long-term outcome. What are the types of TGA with aortic arch abnormalities? We have those with TGA intact ventricular septum with coarctation, and those with TGA with anterior malalignment VSDs. We're also going to talk about areas of outcome by defect type. I'll talk to you about median follow-up, mortality, reintervention rates, freedom from reintervention, and then specifically we'll focus on the LVOT and arch reinterventions. So when Tara and I were chatting yesterday, one of the questions we asked ourselves was, when we say late outcome or long-term outcomes, what does that mean? When I was growing up as a fellow and a young faculty member in the 90s, my surgeons, if they had a patient survive to 2 years, that was a late outcome. That is obviously not a late outcome. So I think what Tara and I agreed on is that midterm outcomes are 5 to 8 years out. And if you're more than 10 years, you can probably call that a later outcome. I think most people would say 15 years. As I delved into this topic, I made it 10 years because literally if you say more than 15 years, there are only 3 papers that you can even talk to about this particular topic. So the purpose of this talk, I will not discuss the typical late outcomes of the standard arterial switch operation. You will hear about that from me tomorrow when I talk about TGA late sequela. So I know that Diane did a wonderful job talking to us about anatomy, but I want to make sure that we all have an understanding of the epidemiology of this specific group of patients. The papers that you see on the right from Dr. Castaneda from Boston, Dr. Piggott from CHOP, Dr. Warnofsky from Boston, Dr. Losay from Paris, and Dr. Saris account for 2,500 transposition patients. And I painstakingly went through all the papers and I added up all the data, and this is how it breaks out. And I want you to remember the 2/3, 1/3 rule. So in detransposition, 2/3 of the patients will have VSDs, and I'm sorry, 2/3 of the patients will have an intact ventricular septum, and 1/3 of the patients will have a VSD. Of those that have TGA with intact ventricular septum, 95% of them will not have coarctation. 5% of them will. Very rare, but you will see it. In the 1/3 that have TGA and VSD, 2/3 of them will not have a malalignment VSD, and 1/3 of them will have a malalignment VSD. Again, the 2/3, 1/3 rule. So when we're talking about what we're talking about today, we're talking about the right side of this diagram, the 1/3 of patients with TGA VSD who are basically likely to have a non-malalignment VSD, but most of what we'll be talking about with Tausig Bing is obviously the anterior-malalignment VSD patients. So in the DTGA VSD anterior malalignment group, there are non-Tausig Bing patients with arch hypoplasia, coarctation, interrupted aortic arch type A, and then there are Tausig Bing patients. And I think Dr. Fraser's comments about how complex it is to look at these specific aortic arches in this group, and sitting down with the echocardiographer is key, but not sufficient, and that you have to leave the OR without arch obstruction is a very, very important lesson for all of us. So, again, what I found here are papers that basically have more than 10 years follow-up. And it was less than 10 years I did not include in this analysis. There are literally 3 papers that have more than 10 years follow-up for TGA intact ventricular septum that have patients with coarctation in them. And this is the Warnofsky, Losay, and Saris papers. And what's clear is that the mortality, just like a TGA patient without VSD who has no coarctation, mortality risk is less than 1%. Our surgeons are so good today, they can do switches with an intact ventricular septum, they can fix the arch, and there's no increased mortality risk. What is the risk of aortic arch reintervention? So this was really interesting. Obviously, when you do a transposition surgery, you do it through a sternotomy, not a thoracotomy. So the actual arch reintervention risk in a child with TGA with intact ventricular septum with coarctation is actually less likely than the standard coarctation patient because our surgeons are doing the sternotomy. And the sternotomy approach, this low reintervention rate is basically 4% versus 13%. Now, the sternotomy approach has less artery obstruction than those undergoing extended end-to-end by thoracotomy, 92% versus 61% freedom from reobstruction at 10 years. So that was something I didn't know before, and I thought was really, really interesting. So now let's move to the second group. These are TGA patients with VSD with arch hypoplasia, coarctation, or interrupted aortic arch. These are not Tausig Bing patients. I'll come to them in a second. So in this analysis that I did, I'm assuming that the tricuspid valve and RV are of normal size, and these patients are having a single-stage biventricular operation. And again, when Tara and I chatted, we said greater than or equal to 10 years. So there's very limited multi-center data or large sample single-center data in this particular group. There are 3 papers, and we'll talk about 2 of them. So the first one is from Paris. This is from Barato from 2016. There were 220 children with TGA with VSD, 29% of which had aortic arch obstruction. The median follow-up was 17 years. 86.4% of the patients survived their index operation, so approximately 14% of them died from their initial operation. And then the conditional survival, once you got past that first index operation, you survived 96.7% of the time at 25 years. So, Dr. Cooper talked about this morning, looked at the STS data. If you have TGA, VSD, and you have an arch obstruction, again, non-Taussig vein for a second, there is an early index case mortality risk, and it's not insignificant. But once you get past that index case, you have a 97% chance of surviving to 25 years. Interesting, only 6.8% of those patients required intervention for recardiation, either balloon or surgical repair. What was also interesting was that aortic arch obstruction was associated with death or reintervention if you survive your initial index operation. So again, to Dr. Frazier's point, you got to leave the OR without arch obstruction. If you don't in these patients, they will have a higher risk of death. The second patient I want to show you, this is a multi-center paper, obviously CHSS data set. This is Dr. McCrindle's paper from 2005, 33 institutions, 472 children with interrupted aortic arch, of which 28% of them, 130 out of 472, and interrupted aortic arch type A. And as as all of you know, and Diane will support this, and so will Justin, who's in the audience, the vast majority of patients that have interrupted aortic arch type A will also transposition. So now I have a cohort of 130 babies that we can look at. So in this particular study, the median follow-up was 17 years. The overall survival was only 59%. Again, this is for type A and type B for the overall cohort. But what was really interesting was that the mortality for TGA interrupted aortic arch type A versus normally rated great arteries interrupted aortic arch type B was better. 26% of the babies with TGA interrupted aortic arch type A died versus 44% of the normally related great arteries interrupted aortic arch type B. Fascinating. Again, before I did this lit search, I would have thought, frankly, that the type B patients did better than the transposition patients. Normally great artery interrupted arch type B and type C was associated with death, not TGA interrupted aortic arch type A. Again, a surprise to me when I looked through the literature. LVOT procedure under subsequent artery intervention occurred in almost 50% of patients, and it significantly impacted the long-term outcome in terms of survival. So as we progress now from TGA VSD without interrupted aortic arch, now to interrupted aortic arch, once you get interrupted aortic arch, a much more complex group of patients, much higher mortality rate, much greater reintervention rate, and if you have, again, subsequent arch or LVOT issues, it does impact your long-term outcome. I want to move now to Taussig Bing. So as a cardiac intensivist, and Dr. Cooper will tell you about this, when I hear that my surgeons are doing a Taussig Bing case, it's a Super Bowl case. So it's way more complicated, in my opinion, than a stage one. It requires whoever is the leader of cardiac intensive care, one of the senior cardiac intensivists, to be an extra set of hands for that patient. Because in these surgeries, you're generally doing a baffling procedure from the LV to the aorta. You're doing a switch. You're doing a coronary reimplantation in a patient that generally has abnormal coronaries. You may be doing a transannular patch, and you're fixing aortic arch. That's all. And these patients come out very sick. And you have to have senior cardiac intensivists working with your surgical team to make sure these patients are monitored incredibly closely. So I borrowed this slide from Dr. Naj, I thought it was a great slide. And he put Dr. Van Praag's definition of Taussig Bing, and to Diane and to Justin, I apologize profusely for not putting Andersonian here. Double atlar right ventricle, large subpulmonary VSD with transposition physiology, bilateral conus without pulmonary mitral continuity, side-by-side great vessels. Often they have anterior malalignment VSD with right ventricular outflow tract obstruction and aortic arch obstruction of some kind. And very frequently, they have complex coronary arrangements. So I'm going to show you 3 papers. Tara in her talk mentioned 2 of them. Again, you had to have more than 10 years follow-up, and there had to be a significant portion of the patients in the study with TGA VSD, Taussig Bing anatomy with arch obstruction. So this study by Frick came out in 2020, literally just came out. This is from the Melbourne group. So they published on 844 arterial switch operations with biventricular repair, 28 of which, only 3.3%, had TGA VSD Taussig Bing type. 50% of them had abnormal coronaries, and 100% of them had aortic arch interventions. Median follow-up was 17.5 years. I thought this was quite amazing. 100% survival. So remember what I just said a second ago? I think of these patients as basically Super Bowl cases. 100% survival in this cohort of 28 babies with Tausig Bing. I thought I was pretty impressed. 54% of the cohort reinterventions. Now, freedom from reintervention was 61% at 5 years and only 56% at 15 years. So in this cohort, a lot of reinterventions, not death. The most common reinterventions were for branch pulmonary artery stenosis and repair of recurrent left ventricular outflow tract obstruction or aortic arch obstruction. What was interesting to me was that a very small number of patients had new aortic valve surgeries, and only 2 patients in this whole cohort had a coronary bypass graft. So remember, very abnormal coronaries, as you'll see as I move through the second and third study, abnormal coronaries are associated with death in the longer term. So, but in this particular cohort, at 17 years out, only 2 patients actually had to have something done to the coronary arteries. Second group now, this is from Paris, 2015. 69 babies with TGA VSD with Tausig Bing anomaly, 65% had abnormal coronaries, 38% had aortic arch intervention in this group. Their median follow-up was 11.2 years. Of interest, 14% died in that first year post-op, and this speaks to Dr. Cooper's data he showed from STS this morning. These babies have an early hazard when they have their index operation. 86% survival at 10-year survival. So literally no deaths in this cohort after the first year. In this group, mortality was related to abnormal coronary pattern and myocardial ischemia post-op, and these babies basically died after the index operation during that first year from coronary ischemia. 40% had reintervention. Freedom from intervention was 53% at 10 years, consistent with the prior case. Again, most common interventions here were branch PA stenoses, and the repair of recurrent LVOT and aortic arch obstruction, and then a small hazard for the aortic valve repair. And only in this case, there were 2 patients at coronary bypass grafts. Third case, third study, I should say, and this one is from Melbourne. This is from Sosin and et al., 2011. They published 57 Tausig Bing patients. Again, 50% abnormal coronaries, 30% aortic arch interventions, median follow-up 10 years. Again, 6% died in the first year, 94% survived to 15-year survival. Again, this early hazard, and then you survive. What was interesting in this case is this group was banding patients before they actually did their single-stage procedure. And I'm interested in the Q&A period to talk with the surgeons about why that might be. Their deaths were not related to abnormal coronary patterns, related to banding. From a reintervention standpoint, 24% of the cohort reinterventions. Freedom from reintervention was 75% at 10 to 15 years. It was better. And of the 3 cohorts, this is the one that had the least reinterventions by far. The only reinterventions in this group were really for recurrent LVOT or arch obstruction at 7%. So, in conclusion, let's put all this together. If you have TGA intact ventricular septum with coarctation, mortality is not different than standard TGA intact ventricular septum with a very low arch reintervention rate due to the sternotomy that the surgeons are doing. If you TGA VSD with arch hypoplasia or coarctation, you have a lower survival than TGA VSD without arch obstruction for your index case, but a very, very high long-term survival after that index case. Getting more complex now. If you have TGA VSD with interrupted aortic arch type A, you have definitely a higher, almost 15% mortality rate than the TGA VSDs, which is only 5%, but it's significantly better than kids with normally really great arteries with interrupted aortic arch type B or type C, which was a surprise to me. TGA VSD with interrupted arch type A has a significant LVOT and arch reintervention rate that does impact long-term outcome. And this, to Dr. Frazier's point, you have to come out of the OR without arch obstruction. Now when we get to Tausig Bing, I knew that a lot of these patients had normal coronaries, but literally it's 50 to 75% of them. And aortic arch intervention is very common. 10% mortality in the first year. In none of those 3 cohorts was there any mortality thereafter. Greater than 85% survival at 10 and 15 years follow-up, which was really surprising to me. If you asked me if Tausig Bing's, how they did long-term, I would say that there would be a longer-term loss of patients. That's not what the data is telling us. So in terms of reinterventions, 25 to 50% of patients, they have reintervention. Freedom from reintervention is about 50 to 75% at 10 and 15 years follow-up. The most common reinterventions are on the branch PAs or for LVOT and or aortic arch obstruction. And surprisingly, reintervention for aortic valve insufficiency and coronary stenosis with myocardial insufficiency was rare. I want to thank you for your time, and hopefully we'll see you in Cleveland someday.
Well, this is a pretty powerful session with some pretty powerful speakers. I'd like to ask the remaining speakers who spoke in this session to come up. So that's, let's see, we had Diane, Spicer, and Kurt to come back up and join us on the podium. And we'll be able to spend about 10 or 15 minutes again with a little bit of a discussion. And while people are kind of getting up here and getting together, I'm going to take advantage of Tara being on the screen. And I think you did a, hey Tara, I think you did a brilliant job putting together all those different CHSS studies. And I wanted to talk a little bit about the concept of following these patients over time, and maybe you could comment a little bit about not only what we learned by following them over time, but how we can do better tracking patients over time and making and doing a better job taking care of future patients based on the lessons from longitudinal outcomes. I mean, nobody really knows more about that than I think you. So talk about that a little bit.
Yeah, so I think the lesson, and obviously there's limited time, but one of the main lessons from the CHSS is that the transposition cohort enrollment numbers reflect the ability to liaison directly with the centers and collect essentially every baby with transposition that was born at those centers over that 4-year period. By the voluntary nature of the CHSS database now, that opportunity is lost. One of the things that Jeff, you know, from many years ago, when we had a lot more energy than we do now, we created the STS-CHSS linkage. And while the linkage was never operationalized, the basic premise of this demands a reprise. And I think we should really put our heads together as societies as how to get the denominator of patients within the CHSS and take advantage of the STS's ability to engage with every center, enroll every patient, and then on the long-term follow-up side, leverage the vehicle of the CHSS, which really has outpaced any other group in its long-term follow-up and its robust data collection. Bill Williams used to talk about the differences between a registry and an academic database. And the CHSS is truly an academic database, and as such is such a rich repository of the types of information on which practice-changing inferences can be made. And I think although the STS is an amazing repository of information, it's a registry, and as Bill Williams rightly said, you cannot collect all of the patients or all of the information. But if you collect all of the information on some of the patients, we might learn something valuable.
I think it's very well said. It's not good enough to only know if they're alive or dead when they go home. We have to be able to do better. Hani.
Yeah, thank you so much, Tara, to Chuck. So at least you were not here this morning. We're talking about the LA line. And we had,
Did you have a good debate?
yeah, we
Good.
said LA line and everyone. I'm glad you do the same thing. So Harry's transposition switch. Dave said no. He's never seen them.
Come on, Dave.
So my question to you is, and I do agree with you, actually, almost all arches in transposition, especially because you translocate the aorta backwards, actually getting closer to the ascending. You can almost always get the descending aorta to the ascending aorta without an arch patch. Can you elaborate a little more about the techniques for the tau signaling when you have a discrepancy in sizes as well as abnormal coronaries? What's your tricks on this to deal with these single coronaries and these coronaries that are branching into 5 branches as they emerge of the aorta?
Yeah, well, yeah, I do modify my technique significantly for the Taussig Bing hearts. So my standard technique is transect the great vessels, mobilize the coronaries, make trapdoor flaps, anastomose the coronaries, do the LeComte maneuver, put the aorta back together. And because you can always see where they're going to go in an anterior-posterior relationship. Not so in the Taussig Bing, because you don't know exactly what that route's going to look like when it's distended. And I think that's where surgeons get into trouble, where I've gotten into trouble. So I put the aorta back together in that. Do the arch, mark the commissures, put the aorta back together, take the clamp off, and see where those coronaries have to go. And they'll tell you where they have to go.
And good, that's what exactly I do, I have to say. Sometimes the RCA writes above the distal suture line.
Yeah.
You just have to deal with it.
Yeah,
But I agree with
You
you.
just have to go where it says that this is where I have to be.
Exactly.
How do you mark the commissure?
I'm sorry?
You said marking the
Oh, yeah,
commissures. How do you do that?
You know, when you have the aorta open, you just put a 7/0 stitch through and tie it on the outside, so you
And then you know where it is.
where the tip of the pillar is, so you don't
Yep.
booger up the pillar when you make your
Sure.
arteriotomy. And I'm liberal with the trapdoor flaps, but some of them actually in the Taussig Bing, the root is so big that you don't do that. You make direct osteoanastomosis.
Absolutely. Brad, I have a question for you. You're talking about, and rightly so, 15 years is probably just starting to scratch long term. And as just the last comment of Dr. Fraser about the large roots, they have huge roots. And now with Justin Tritter, we're looking at the site of the coronary implantation versus the aortic incompetence and so on. I think we really need to look definitely more than 15 years with those patients because as we see them, they are sporadic cases now, obviously, as they've survived no longer than 15 or 20 years. They come with new AI. They come with large roots reaching 5.5 and 6 centimeters. They come with all this. So where do you see that we should, or how do you see that we should follow these patients up? And we do see them come with different types of problems, and as again, I quote Bill Williams, actually, every patient is going to have a complication. It all depends how long you follow them up. And if we say 20, you haven't followed them for 30. If you say 30, you haven't followed them for 40. So there's always something that comes up late.
I mean, I'm all about being efficient with follow-up. And can you guys hear me?
Yeah.
Okay. I think what Nick was talking about this morning in terms of doing the MRI stress test, just do the same time the MRI stress test, and this way you get a sense for the myocardium in terms of its ability, to receive the blood flow, and you get a great anatomic assessment. And from the MRI, you can easily get a reconstruction there that'll be very effective to look at the appropriate orientations of the root, the coronaries, et cetera. The standard TGA literature, when you look at root dilatation. And Merrill Cohen showed this with kids with HLHS. I showed this with kids in the Ross procedure. We've shown this also with kids when I was at CHOP in our arterial switch operation population. The roots, they all dilate, but you don't get a lot of neo-aortic insufficiency. I think what was surprising to me and what I showed today was that you don't get more neo-aortic valve replacements, valve spring root replacements, et cetera. I think with the Taussig Bings, it's a much bigger problem because you have this big size mismatch. And the surgeons, you're trying to make the size match up as well as you can, but then over time, you're going to get a lot of root dilatation. What does it do to the coronaries? Again, I was shocked that the coronary interventions were as low as they were, because when you look at the papers in Taussig Bing, 50 to 75% of them have very unusual coronary patterns. And I know that all of you are customizing that in the OR. Sometimes you literally do a PA translocation to try and get it out of the way of the coronary. So I think to answer your question directly, MRI is the way to go. Our cross-sectional images can give us beautiful fidelity in terms of what's going on with the anatomy and where the coronaries are coming off.
Maybe an audience question or the panel question. So I'll bet everybody here has some form of formal AAOCA program going on at your institution because it's such a visible problem. And of course, Tara is very involved in that, and our institution, Carlos Mary, et cetera. I wonder how many centers are enrolling their arterial switch patients that have abnormal coronaries in their AAOCA program. I mean, we're making AAOCA.
Absolutely. Actually, one of the exclusion criteria is normal relation of great vessels.
Right.
So we actually are systematically excluding them. So
Well, they're systematically excluded from the CHSS studies, but
But I think that the notion of what happens with these coronaries, in Boston, they had a protocol that I think is one of the ARC quality metrics for adult congenital in terms of the surveillance program for switched arteries in transposition. And I think your point is an excellent one, Chuck, that we do need a mechanism in a way to understand, what's happening with these coronaries. And I think Justin had some questions, which I'm sure you guys will discuss on site there, about the height of the coronaries implanted and root dilation. And some of those, I think, aortic and coronary relationships probably have interactions with one another. So I think it's important potentially for both types of late sequelae.
I think, Brad, your observations about the follow-up of the Taussig Bing patients is fascinating. I think the next decade that curve is going to start to change, because I know we look at patients that have had moderate, trending towards moderate plus neo-AI, and we think, well, that's going to be a really difficult redo root operation, and we just watch them a bit longer. So I think those are going to start to rear their ugly head in the next 20 years.
And when our surgical colleagues start going in and fixing these roots, and hope it's valve sparing, if it's not putting in mechanical valves or artificial valves, you're going to be dealing with the coronaries.
That's going to be a real operation.
Yeah. So,
Diane, I have a question to you, Diane. With the high percentage of abnormal coronaries in the Taussig Bing, the way I look at it, or I at least explain it in my head, is that the septal arrangement, the septal direction, the interventricular septal direction is not in line with the coronary distribution. And that's why you end up actually with unnamed coronary arteries in the Taussig Bing. You don't actually have all the time the LAD, the circumflex, and so on. You just have branches that supplies coronaries. So do you agree to this? Or what, because we don't have an LAD insert. We do most of the time, but 50% of them have just very weird branching of the coronary arteries.
Yeah, I agree with that observation.
And
I don't know.
it's the septum,
how to
which is
explain it, but-
completely in different alignment with the great vessels.
Right.
Yeah. That's what I thought.
I'd like to ask one more question directed down towards Kurt at the end. I really was fascinated by your talk about the different types of error and how precise we can be when we're looking at fuzzy dots on a TV screen, then trying to draw lines connecting two of them. How do you relate that percentage of error to the efforts of trying to delineate the coronary anatomy preoperatively in a patient with transposition when those vessels are really small? And we want to know, is it the usual coronary arrangement or is it intramural? How precise do you think we can be prior to an arterial switch? And what are your indications for doing more advanced imaging beyond echocardiography?
The comment I want to make about the arch and whether or not to get a CAT scan, I think for me, I'm addicted to CT scans.
That's right.
I can sleep better at night.
That's right.
And then sometimes we're guessing echo images are not that pristine, so forth and so on. As far as identifying vessels, I think you can identify vessels, but be cautious about their size, is the way I would look at that.
You can tell us if there's something funny about them. I mean, that's my sense. I mean, the echocardiographers can say definitively this is, I mean, I can see it come out of the sinus, or there's something not right about this origin. That's good enough for me.
But I know one thing, when the echo tells me that the arch size in a coarctation is 1 millimeter above the weight, I doubt it. So it's always less, so it's
Yeah,
more
no.
equal.
Oh, and we saw some data today with some pretty fancy mathematical formulas about how one can measure that error, which I thought was pretty, I mean, that was amazing, actually.
I'm just going to be a curmudgeon about it. I think that, that the echocardiographers can get it. I think if they'll just be persistent. I see in our institution, I mean, you can't get in the ICU without getting a CT scan now. I mean, it's like a chest x-ray.
Yeah.
CBC.
Yeah, CBC CT scan.
Yes, right.
Depends on whether or not the chest is open, actually.
Well, I mean, Chuck, almost this is like for cardiologists, when there was no echo, we were amazing auscultatory, individuals, right? I mean, you could literally put your stethoscope on a chest back, and then Fran remembers the days, when we were fellows, you walk in with a senior cardiologist, they would just put they could tell you the diagnosis.
What's a stethoscope?
Exactly.
Exactly.
But that's my point. That's my point. I think, back in the day when, there was just echo and CT and MRI really weren't there. I remember literally as a fellow, Merrill was, 3-4 years ahead of me. She would be in the ICU with me for 2 or 3 hours until she got the coronaries.
Mm-hmm.
Now, don't misunderstand. I'm not saying that our imagers today don't absolutely try to get every single anatomic bit of data, but if you can't get it, you can very easily get a CT or get an MRI, which gives you, frankly, much more exquisite information, and it's easy to get. Now, to your point, Chuck, it's never, for free, right? Again, the CT is not for free. Again, the MRI is not for free. Moving patients that are high-risk patients to the dark bowels of radiology to get these things done. It's what gives me and Dr. Cooper heartburn all the time we're on service. But, I think that's one of the things that's happened. I think we know now that we have these modalities, these cross-sectional imaging modalities that are so exquisite that we may not be persisting as we might have before with echo.
Dr.
Well,
Barrett.
Carlos, Mary, and I argue about this every day, so we're internally divided about it too.
Dr. Barrett.
The stethoscope is something that the cardiologist uses after they've looked at the echo.
That's right.
They think, yeah, I think there's probably anterior mitral valve prolapse.
That's right.
So I just landed. So you may have had this discussion already. In these complex transpositions with VSD, it always seems that the right thing, because the morphology is so suited, that a primary repair is the right thing to do. Do you think there's ever a place for a staged approach? Because when I've looked at some of those papers, and it surprises me that you can't really say that a primary repair has better outcomes than a staged approach in most of these big series. Is that a situation?
It's anecdote, but I can definitively think of a life I said, because it was a single coronary between the great vessels, and I couldn't get it to sit right. I tried to translocate it. I couldn't get it to sit right. And I put the aorta back together, and I banded him, and I brought him back at 18 months, and then we got it. So I think it's got to be in there myself. But then, if it's a Taussig Bing heart, then we could end up doubly obstructed if we've not assessed the subaortic area well. I don't know.
Chuck, this is what my comment before about that one of those 3 papers in Taussig Bing, that the high risk mortality were in the patients that they had banded first and then done a second stage on. And David, welcome. So glad you're here. To your point, if you look at the literature, and I just looked at all of it in the last couple of weeks, there are several papers that would say a single stage has a better survival than a staged approach. But I don't know if you can think about it that way, because it could be that for that patient to survive, you had to do a 2-stage, right? And these are more complex patients that you knew you couldn't do a primary stage on, a single stage on. So there's a reason why the 2-stage is more likely to have mortality than the single stage. They're just a sicker group of patients that it's not, again, it's not simple whenever you do a Taussig Bing, but it's not as straightforward, let's do all the things we do with a Taussig Bing repair, and you have to do some other palliative procedure first.
Yeah, I agree. And I think the surgeon should really make sure that his or her ego doesn't actually be in the way of a survival. That's one thing. And that's a very humbling comment that you said, Chuck. So if that's what it is, that's what it is. Take the palliative approach, but you have a survival and you can get back at it. That's one. But I do think that there is a place for palliative approaches when you have medical issues going on with the patient. So don't, insist on something that you got to do this big operation because you're good at it, while you know that the patient has some renal dysfunction, has some chest infection, has this, has that going on, which is not related to the cardiac, and all of a sudden they pile on you after a complex operation. But very, very important. I think we should not have our egos stand between us and survival of the patient.
Well, I'd like to thank everybody. This was a great session and a good discussion. We'll take a break, and we're going to come back at 3:30, 5 minutes after it says on the piece of paper, for the final session, which is a really challenging group of patients, those with transposition and functional univentricular hearts.